Assalamu alaikum. I am lsraa Okap, lecturer of pathology at pathology department, and today inshallah we are going to discuss glimpses of diseases of male genital system. Starting with the diseases of testes, we are going to discuss the testicular neoplasms, and its importance is that testicular neoplasm are the most important cause of firm, painless lump in the testis. So if there is enlarged testis and the patient feeling a lump that is painless, the first differential diagnosis is going to be testicular neoplasm. لازم في الأول نعرف what is the normal structure of the testis. The testis is formed of as you see here, multiple seminiferous tubules, and these seminiferous tubules lined by the spermatogenic elements or the spermatocytes at different degrees that at the end yield to the sperms. And there is also Sertoli cells, and in the stroma we have interstitial cells of Leydig. This is a normal structure. So every cell of these cells is going to give a different neoplasm. And the characteristic thing about testicular neoplasm is that it could be from single origin or a single entity, or it could be mixed germ cell tumor with other cell, as we are going to see. As you see here, the testicular tumor could be 6-cord stromal tumor arising only from the stromal cells, and this only 5% of testicular tumors, and it could germ cell tumors arising from the germ cells, and it's only 95% of testicular tumors, and it could be combined. According to the WHO classification, we can see here that we have tumors of one histologic pattern, which is seminoma, embryonal carcinoma, yolk sac, choriocarcinoma, or we have tumors with more than one histologic pattern. It could be mixed embryonal with teratoma or choriocarcinoma with other germ cell tumor, and it could be seen. Or we have 6-cord stromal tumors that are arising from Leydig cell, so we have Leydig cell tumors, or Sertoli cell tumors. The pathogenesis. كلنا عارفين that the neoplasm is a multifactorial disease. It couldn't be referred to only one cause, but one of the major or the most important risk factors of testicular neoplasm is cryptorchidism, or undescended testis. The normal place of the testis is the scrotum. So if it remains in the inguinal region, it is in abnormal place with abnormal environment, abnormal temperature. So it is a major risk factor of developing a neoplasm in the testis. Also testicular feminization or Klinefelter syndrome. There are genetic factors as evidenced by the high risk of testicular neoplasia among siblings. The tumors that we are going to study thoroughly: seminoma, embryonal carcinoma, yolk sac tumor, choriocarcinoma, and teratoma. Starting with seminoma. Seminoma is the major germ cell tumor we are going to discuss in details. It is the most common germ cell tumor in adult, represents 30% of testicular germ cell tumor, and it is very rare in childhood. It affects mostly in the patients in 4th decade. It's the counterpart of dysgerminoma in female. Grossly, this tumor have a characteristic. كلنا عارفين when we are going to describe a neoplasm, we have a common description. It is a lump, ill-defined, grayish-white, hard inconsistency. It's okay. This is all typical for seminoma. But here there is a characteristic thing that the cut section of this seminoma is homogeneous. Very rare to detect necrosis or hemorrhage in seminoma, only in a very large tumors. But the default that you are going to find a large homogeneous tan or grayish-white tumor infiltrating, or it could replace the whole testis, and it's very rare to detect hemorrhage or necrosis except in very large tumors. And sometimes, or usually, it's confined to testes, but sometimes it can infiltrate the tunica, but in most of cases we find that it respects the tunica alpogenia in distension. Microscopically, we are going to find two types of cells. The seminoma cells or the tumor cells in the neoplastic cells, they are nests or lobules of large tumor cells, polyhedral, having large central rounded nucleus. And another type of cell, which is the lymphocytes. This is a non-neoplastic cells. This is an inflammatory cells detected in the fibrous septa that separated these tumor lobules. So as you see here, you have tumor lobules formed of large cells with distinct borders. Its cytoplasm could be vacuolated or clear, glycogen-rich cytoplasm, have a rounded nucleus with prominent nucleoli. It's arranged in lobules and separated by these fibrous septa that contain lymphocytic infiltrate. Regarding the embryonal carcinoma, this is another type, a pure embryonal carcinoma that's not mixed with other types, only constitute 30% of germ cell tumor, but it could be mixed with other tumors in 40% of cases. It's common in second or third decade, and it's more aggressive. Yani, as we discussed, you will find that seminoma is the kindest type. Most of the coming tumors have worse prognosis than seminoma, so it's more aggressive than seminoma. Grossly, it appears ill-defined, not respecting the boundaries as seminoma. Invasive neoplasm. Here it have multiple areas of hemorrhage and necrosis against seminoma, and may extend through tunica alpogenia into the epididymis or spermatic cords. You here can detect the difference between seminoma and embryonal carcinoma. As you see here, it has multiple areas of hemorrhage and necrosis, and here it's replacing the whole testicular tumor and infiltrating the epididymis. Under the microscopes, the cell of embryonal carcinoma is large primitive cells with indistinct features, have large nuclei arranged in sheets. And the most characteristic here will be the areas of hemorrhage and necrosis and the aggressive looking malignant cells. Regarding the yolk sac tumor, here it's the most common testicular neoplasm in childhood. So the seminoma is the most common time in adult, and the yolk sac tumor the most common testicular tumor in infants and young children. It could happen in adults, but the pure form only could represent a very minor, not exceeding 10%, but it could form 40% if it's mixed with other germ cell tumor. And here we have a very important marker to detect and follow up this tumor, which is the alpha fetoprotein. It's abbreviated, اختصاره AFP, alpha fetoprotein. It's elevated in 100% of cases. Grossly, this tumor is not encapsulated. It's homogeneous, and it have a characteristic yellowish color, and it could be detected grossly and help us to diagnose or predict that this case have at least a yolk sac element. It have a yellowish white tumor tissue. As you see here, it has multiple areas of hemorrhage and necrosis. Under the microscope, it has many patterns. It could have it could be formed of cords, lobules, sheets of cuboidal or columnar cells. As you see, sheets or glands or papillae or microcysts. It have eosinophilic hyaline globules, but the most characteristic structure here called Schiller-Duval bodies. What is Schiller-Duval bodies? It's a characteristic structure resembling the glomeruli. You know the glomerulus of the kidney. It's a structure resembling this structure. Have this cystic structure with hemorrhagic content and lined by these anaplastic tumor cells. So the presence of structure resembling these glomerulus as Schiller-Duval body is a characteristic feature of yolk sac tumor. Here we have the choriocarcinoma. It's a highly malignant testicular tumor. one of the important tumors that spread firstly by blood. Hematogenous metastases occur very early, and it could be to the liver or the lung. To occur as a component of mixed, it could be mixed with other germ cell tumor, and it occur in younger age than seminoma, 20s or 30s. Grossly, the tumor here have a characteristic thing that it's spread hematogenously early, even it has a small size. It could be small even in the presence of a wide systemic metastasis, and it have extensive hemorrhage and necrosis. And under the microscope, it's formed of you know choreo. It will remind you هتفكرنا دايما بالchorionic villi, the products of conception. So you will remember that the choriocarcinoma is formed of cyto and syncytial trophoblast, but here it's the malignant form. It's formed of malignant cyto and syncytial trophoblasts. Here we have the teratomas. You could أكيد سمعتوا this term before. The word teratoma, it means tumor arising from the totipotential cells. A group of neoplasm have a three-layer differentiation: endodermal, mesodermal, and ectodermal line, and it could occur in any age. Grossly, this tumor has a variegated cut section. It could have cystic structure, as you see here, and this cyst could contain cartilaginous areas, and under the microscope, you remember this teratoma can have any type of tissue inside it. But according to the maturity, we can divide it into mature, immature, or other types, as we are going to see. So under the microscope, if these all tissues are rising from different layers is mature, يعني كلمة mature means resembling the adult or the normal tissue, it is called mature teratoma. If we have a mature or fetal tissue, it's going to be called immature teratoma, and this teratoma could have a tissue that has malignant transformation. So the mature teratoma, it's fully differentiated tissue, has 3 germ cell layers. We could find ectoderm as neural skin or skin appendage. We can find hair and hair follicles and sebaceous glands. Mesoderm, we can find muscle, cartilage, adipose tissue, fat, lymphoid tissue. We can find endoderm, bronchial epithelium, gut or glandular element. These all mature, and these mature teratoma are more common in infant and children. Immature, it also contains the 3 elements, or the elements of 3 germ cell layer, but here in incomplete stage. Some of this tissue, and usually it is the neural tissue, the nervous tissue, that in this tumor is immature or not fully differentiated, and here it's considered malignant, and it occurs especially in adults. And in teratomas, one of the tissues inside it could have malignant transformation, characterized by frank malignancy. So the skin could yield a squamous cell carcinoma, a gland could form adenocarcinoma, so it could develop in a mature teratoma, and this also occur in adults. So the only type which is a mature teratoma occur in children or adolescent, but the most of teratomas with malignant transformation or immature one occur in adult. So we have a rule: all teratomas in adult should be considered as a malignant neoplasm, because in adult it could be or they have higher incidence of immature teratoma or teratoma with malignant transformation. Clinical features generally of all of these germ cell tumor that, as we said at the beginning of the lecture, all of them are presented by painless enlargement of the testis. They are classified according to if they are seminoma or not, to seminoma and non-seminomatous germ cell tumor. The two groups differ in presentation and prognosis. زي ما قلنا, the seminoma is the kindest type. All other types have worse prognosis. Seminoma remain confined to testis. Non-seminomatous have a widespread metastasis, and at the time of diagnosis, even if the mass in the testis is still very small. The seminoma prefer to metastasize by lymphatics to para-aortic or iliac lymph node. Hematogenous spread unusual, وده طبعا be confirming the gross picture that it has a very little hemorrhage or necrosis. So the spread first it spread by lymphatics, but all non-seminomatous tumors, as they have wide areas of hemorrhage and necrosis, malformed blood vessels, it potentiates the possibility of hematogenous spread. So as we see, non-seminomatous germ cell neoplasm tend to metastasize early by lymphatics, and hematogenous routes to liver and lung. It prefer both. Seminomas are radiosensitive, and non-seminomatous germ cell tumor relatively radioresistant. Clinical staging, we have stages according if this tumor confined to testis or extend beyond. So the stage 1, it's tumor confined to testis. Stage 2, it metastasized to the retroperitoneal nodes below the diaphragm. If it arises above the diaphragm, it will become stage 3. The tumor markers here have a very important role to diagnose this tumor and to follow up this tumor and to detect if this tumor is completely excised or not. So we can evaluate the testicular mass. If we have alpha fetoprotein rising, we can suspect yolk-sac tumor. The staging of this germ cell tumor, monitoring the response of therapy if it decreased or vanished, diagnosis of recurrence in case of follow-up. So alpha fetoprotein, as we know in yolk-sac tumor, and we have HCG or human chorionic gonadotropin in choriocarcinoma. The 6-cord stromal tumor, all of these tumor were germ cell tumor. 6-cord stromal tumor, we have Leydig cell tumor. It's a very rare tumor, occur at any age, secrete androgen, so it has manifestations and other steroids as estrogen and corticosteroids. The tumor here have as you see, a well circumscribed nodule, yellowish brown homogeneous cut section, and under the microscope it's composed of polygonal cells that have abundant eosinophilic cytoplasm and have lipid droplets. This is the hormones. Clinically, it presents with painless testicular neoplasm and the hormonal manifestation of the hormones secreted by this tumor, as gynecomastia in adult or precocious puberty in children. 90% alhamdulillah are benign and have excellent prognosis. Only 10% could be malignant. Sertoli cell tumor, it's a very uncommon tumor formed arising from Sertoli cells, and most of them alhamdulillah are benign. Only 10% could spread or infiltrate the surroundings. So we finished the testicular tumors. Regarding the prostate, we will discuss one non-neoplastic issue, which is prostatic nodular hyperplasia, and one neoplastic, which is prostatic adenocarcinoma. Regarding benign prostatic hyperplasia, it's hyperplasia of both elements. As you know, the prostate is formed of 2 elements, glands and stroma. The glands is lined by 2 layers, the luminal cells and the myoepithelial cells, and it's surrounded by a fibromuscular stroma. So in this case, the hyperplasia occur of both elements, the glandular element and the stromal element. It occurs in 20% of males above the age of 40, and as the age increases, the incidence of PPH increase. What is the pathogenesis of this benign prostatic hyperplasia? Here it's hormonal. The circulating testosterone have a form called dihydrosterone, DHT. It is formed by 5-alpha reductase type 2 action of this enzyme, forming the DHT, which bind to the nuclear androgen receptor. بيعمل إيه؟ It works as a growth factor. It stimulates the prostatic glands and the prostatic stroma to proliferate. So the increase of this element form hyperplasia of both glands and stroma. As you see here, this is the prostatic urethra and this is the normal prostatic structure. The affection of this androgens or androgenic growth factor affecting the periurethral part, forming periurethral nodular hyperplasia. طب وإيه المشكلة? What is the problem? Here all the manifestation will be in the urinary system. It's difficult urination, dysuria frequency, because it's surrounding the urethra and compressing it. But here, as we will talk about the prostatic adenocarcinoma, the carcinoma usually peripheral or subcapsular. So it's very rare to affect the urinary stream or forming urinary symptoms. Grossly nodular hyperplasia or benign prostatic hyperplasia will affect, as we say, the periurethral glands, forming proliferation. The prostate is converted into lobules, multiple lobules or nodules, well circumscribed, have cystic spaces. The urethra here is compressed, it couldn't be seen. Sometimes hypertrophic gland may bulge وتضغط على urinary bladder, it appears as a lump, and so it could be one of the differential diagnoses of hardness felt in the prostate. It could be PPH or it could be tumor. Under the microscope, زي ما قلت لكم دلوقتي, it's formed of glands and stroma. Here the glands are hyperplastic. The glands enlarged, different in size and shape, have papillary convolutions and contain the secretion. Here, you know, it's called corpora amylicia. But the sign of benignity is that these glands lined by two layers of cells, the luminal cells and the myoepithelial cells. This tell that these glands are benign, and the stroma here are hyperplastic, also fibromuscular stroma. So as you see, we have proliferating glands with papillary projections but lined by two layers. We have corpora amylicia here, the secretion, and we have hyperplastic fibromuscular stroma. Another one, we have glands lined by two layers of cells, and this confirms the benignity of this case. It's a benign case, not a neoplasm. In neoplasm, the myoepithelial layer will be lost. And we have here the corpora amylicia. The clinical feature, the PPH affecting the tissue of the prostate around the urethra. So it will affect the urinary stream. We have frequency, urgency, difficulty in starting or stopping urination, painful urination. It could predispose to infections, cystitis, and pyelonephritis due to obstructive symptoms. It could form stones as infection and needles formation, hypertrophy and dilatation of urinary bladder نتيجة obstruction and the urine remaining inside the urinary bladder. Bilateral hydronephrosis could lead to chronic renal failure. But the most important point here is that no relationship has been established between the PPH and the prostatic adenocarcinoma. The last issue we have is the carcinoma of the prostate. It's the most common visceral cancer in male. The second most common cancer related to death in males above 50 after lung. We occur around 60s to 70s, and it's important point clinically that it's one of the occult carcinomas. What's meant by occult carcinoma? These carcinomas that has a very small primary and couldn't be detected only by metastasis. It could only be detected by metastasis, and we search for the primary, so we are going to find a very small focus in the prostate. What is the pathogenesis? It has many pathways, but you need to know that it is multifactorial. It could be hormonal, because it's very rare in catheterized males. They found that any male that is catheterized or have orchiectomy never develop prostatic cancer. Genetic predisposition, they have that it has a higher incidence in sibling or first relatives. Environmental factors according to the hormonal therapy or anything affecting the prostatic tissue. Grossly, احنا قلنا it's ill-defined mass at the outer or the peripheral, as we say, not around the urethra. It's a peripheral mass at the subcapsular area of the prostate. The cut section is grayish-white to firm. It could be yellowish, ill-defined margins. Under the microscope, it's against the PPH. The PPH or the prostate, one of the organs that if you find the gland large, dilated, and convoluted, you will be calm. It's inshallah PPH. But if you find the glands arranged, small in size, and have a certain pattern, you must worry. It could be prostatic adenocarcinoma. It ranges from poorly to from well to poorly differentiated adenocarcinoma, but it's formed of glands. Glands here, you know, as you see, it's arranged glands, not dilated or convoluted as PBH. And one of the most characteristic features that it's lined by a single layer. No myoepithelial cells could be detected here, and this is confirmed the malignancy. So it's back-to-back glands, loss of convolution, loss of papillary, loss of fibromuscular stroma between these glands. And here we could find a perineural invasion. It could be this gland invades the nerves. As you see here, this is a benign gland. You see it's lined by two layers. You can see here two nuclei, the luminal cells and the myoepithelial. But this gland, as you see, it's arranged small, no papillary convolutions, and only layered by one layer of malignant cells. What is the grading system here? The prostatic adenocarcinoma has a different grading system. It's not graded as well or moderate or poorly differentiated. It's graded according to Gleason's pattern. Gleason stated that if these glands are small, uniform, and arranged in a nodule, it will be 1. Or if these glands become more, has wide spaces between them and have stroma between them, it will be 2. Distinctive infiltrative margins, it will be 3. If it is formed irregular masses and mostly cribriform, it could be 4. And if it's formed cords or single malignant cells, it could be 5. And here, this is not for you to study, but only for your knowledge, that today we are grading the prostatic adenocarcinoma according to ISUP grade grouping system. They combine the pattern. If the prostate have some regular glands, it will be 1 Gleason score, grade group 1, which is Gleason score 6. They combine the patterns. Here you see the pattern 1, 2, 3, 4, 5. So if it have most of the pattern as this gland have the same shape, it will be 3, and 3 plus 3, which is 6, and this is grade group 1. This is not for you to study, only for your knowledge, that if you have a report of anyone to read, and you read that it's a prostatic adenocarcinoma, Gleason grading, grade group 1, grade group 2, you know what is meant by grade group. It's combination of patterns. They see what's pattern of Gleason's here, and they combine the pattern to form this group. According to the stage, if the tumor is confined, find incidentally inside the prostate, it's stage 1. If it's organ confined, it's stage 2. If it has extra prostatic extension, it's stage 3. And if it has direct invasion to any of the surrounding, it's stage 4. Clinically, a very minority of cases are asymptomatic and could be diagnosed by metastasis or secondary tumor, or at autopsy, at the removal of prostatic senile hyperplasia. We can find a focus of prostatic adenocarcinoma. It could be locally advanced with signs of obstruction if it infiltrates the whole prostate, affecting the periurethral tissue, and advanced cases may cause metastasis even to the bone or the vertebrae, forming osteoplastic metastasis. The tumor marker here is very important. It's PSA, or prostatic specific antigen. It's used as a marker to diagnose at the first place the prostatic adenocarcinoma and confirm it, and to follow up if it's completely excised or recurred, or the effect of therapy, effect of treatment. But the most important here is that the prostatic carcinoma may be very small in size and hidden, and it's one of occult carcinoma. So the patient could present it as a first place by metastasis. Thank you.